right, we'll be talking about the skeletal system this week. This is chapter 2 of your pathology book, and there's a lot to this chapter. So there's a lot of describe, identify, explain. Make sure you understand what you're looking at for each of these. So there's 206 bones in the body, and they are responsible for body support, protection, movement, blood cell production. It's divided into the axial and appendicular skeletal. There's 80 bones in the axial skeleton, so skull, osseous, hyoid, ribs, vertebral column. And we can see here the appendicular, and we've got 126 bones. We have the shoulder girdle, arm, hand, pelvic girdle, leg, and foot. Moving along here, the anatomy physiology. I'm going to cover all of this pretty quick because you should already know all of this. So we're looking at the outer portion of the bone is composed of compact bone. The inner is medullary canal made of calcareous bone. The bone marrow is located within the medullary cavity and is interspread between the trabeculae. There's web-like bony structures visible on properly exposed radiograph, and it's called the trabecular pattern. So you'll be able to see the trabecular pattern, and that's how you know if you've got a good radiograph. The red bone marrow is erythrocytes and leukocytes. By the age of 20, the majority of the red bone marrow is replaced by yellow bone marrow, which is mostly fat. All right, so here is the breakdown of the bone. So get to know that, make sure you understand and be able to label. We have osteoblasts. They're bone-forming cells that line the medullary canal and are interspersed throughout the periosteum. They're responsible for bone growth and thickening and ossification. Approximately 99% of the bone's calcium is found within the skeletal system, so certain metabolic processes may alter the percentage in hypocalcemia or hypercalcemia. The bones of the skeletal system may also be classified according to their shape, so long, short, flat, or irregular, and here's some pictures of them. And the 206 bones are connected to each other by one of the 3 types of joints. There's fibrous, cartilaginous, and synovial. So know the different types, and you can see here the how bones work. They pivot, hinge, or gliding. The types of joints also is the ball and socket, saddle, and condyloid. Imaging considerations. So proper technique is achieved when soft tissue and bony structures of the interest are both visible. So soft tissue areas hold clues to the diagnosis and should be examined. Any signs of muscle wasting, soft tissue swelling, calcifications, foreign bodies in the presence of gas may indicate disease. The interference between cortical or compact bone and soft tissue is also important. Any periosteal new bone formation may be seen as a response to trauma, tumors, or even infection. So we look for erosions from arthritis and reabsorption or smudgy loss of cortical margins. So something that's eating away at the bone. Outline of specialized imaging techniques. There's diagnostic imaging modalities such as mammography, ultrasound, CT or computed tomography, MRI, magnetic resonance imaging, nuclear medicine, single photon emission, computed tomography. And there's positron emission tomography, which is PET. The one up above it is SPECT. And then you have fusion imaging where you combine CT or MRI with PET scans. Or nuclear medicine. Imaging features. When a radiologist interprets image, they commonly use terminology called imaging features. So terms used to describe imaging features is the location, the size, the density, the structure, the shape. Does it perfuse? Is it integrated? So they use different terms to help describe. So mammography, we use specialized designated X-ray tubes to provide high-quality images of the breast. There's screening and diagnostic mammography. And you can see here, this is a CC, which we call a craniocaudal projection of the breast. And you can see that this breast is the darker gray is fatty, the white is more dense tissue. And you can see here that we've got some speculated lesion. Something, the architecture right here, it's smooth margins, so it looks like a cyst or something here also. So we've got some kind of speculated, any kind of speculated lesion is suspicious of cancer. All right, so image creation, we use for mammography ionized radiation to attenuate the breast tissue. The image receptors, a digital plate. We can use analog, which is film, very uncommon. There's usually CR or DR, and it's got to be DR moving forward in order to get reimbursements. So imaging descriptors, same as used for general X-ray. Ultrasound, it is non-invasive imaging modality. It uses high-frequency sound waves produced by electrical stimulation of a specialized crystal, so they vibrate. It is a cross-sectional imaging technique, and the advantages of it is low cost, it's available, and ability to differentiate between cysts, solid lesions, and complex tissues. And looking here, we're looking at a gallbladder. So we can see the gallbladder, the common bile duct here. We've got the head of the pancreas, just so you can see. Kind of cool. And looking here, yeah, right atrium. So the summary of ultrasound is you have your image creation. You use a transducer. That's what the handheld unit is called, of what has the vibrating crystals in it, I should say, that produce the sound waves. The image receptor is also the transducer, so it sends and receives the echo signal. And anechoic, which is dark and echo-free, and hyperechoic is lighter, and hypoechoic is darker. So isoechoic is the same. CT, so uses radiation and produce cross-sectional images. Post-processing techniques are available, so we can adjust the grayscale, the brightness of the window, and we can do 3D images. And the scan times vary, and it bases it on how much tissue we're covering and how fast the scanners are. So looking here, this is a cross-sectional of a CT of the abdomen. So we can see the liver over here, gallbladders right there, IVC, aorta, and this is the spongy part of the disc. And we have the stomach here, and this is the pancreas coming across. Here's the tail, and you have your kidney, left kidney, right kidney. All right, and here's your IVC, and so this is your portal. All right, summary of CT image creation. You have collimated X-ray beam for attenuation detectors on the other end, opposite of the tube. And the detectors receive the attenuated signal from the medium, which is typically the patient. And the detectors have CT Hounsfield units that reflect the amount of attenuation of the specific tissues relative to water. So water is a 0. The highest CT number is 1,000. Represents bone typically. It appears white. And the lowest number is negative 1,000, which is air. It's just black on the image. So we have the window width, which is grayscale. It's our contrast scale. And our window level is the midpoint or center of total number of densities. And then we can post-process. We have MIPS, which enhancing the brightest intensities. And we have minimum intensity projections and enhances the lowest intensity. So we do those on when we're looking at colonoscopy work, when we're studying the colon. We have a shaded surface rendering or volume rendering, so 3D, and we have VR, which is virtual reality. All right, MRI. So images are obtained by placing the anatomical part in a strong static magnetic field and directing a radio frequency pulse of a specific frequency at that area. This process introduces hydrogen atoms or protons to alternate between high energy and low energy states by absorbing and then releasing and or transferring energy. This is the modality of choice for imaging of the CNS, spine, and musculoskeletal conditions. So looking here on MRI, excellent for soft tissue resolution and differentiation of tissues. Differences are obtained from a variety of pulse sequences. So scan times are longer. This increases the difficulty of imaging some organs, so especially the heart. Some patients have difficulty with claustrophobia. We have a lot of new scanners that are open, and patients do a lot better with them. So here is some MRI. We have axial. This looks like a T1, and we have a T2 sagittal and a T2 axial there. Image creation for the MRI. We use radio frequencies emitted to change hydrogen atoms and release energy to spin them, basically. The imaging receptor is a coil that we use placed on the patient. There is a body coil built into the magnet that can do it. We don't get as good a detail. And then there's a bunch of different sequences that we can run, T1, T2. We can give contrast, we can do diffusion, we can do fat suppression. There's all kinds of stuff that we can do, and we'll go over that more when we cover MRI. Nuclear medicine. It requires a patient to ingest or be injected with a radiopharmaceutical that emits radiation. The images are created by measuring the signal radiating from the patient. This allows visualization of the pathological process. It detects some disease earlier than other modalities do. So as you can see here, this is a nuclear medicine bone scan, and we watch for any kind of uptake. So if there was a lesion, in the spine, it would be really bright, dark. I mean, I say bright, but it would actually be dark. So a bright black, how's that? All right, so single positron emission computed tomography, so SPECT. SPECT is an aspect of nuke med. It uses the same radiopharmaceuticals, and SPECT camera has the ability to rotate independently around the patient, so it's really cool. A computer uses the data to reconstruct 3D sectional images, very much like CT and MRI. So the images can be transverse, coronal, or sagittal. And here's some SPECT images. Hard to tell, huh? All right, so summary. Image creation, radiopharmaceutical that emits gamma radiation, and the image receptor is a gamma camera. In SPECT, it's a rotating gamma camera, and we look for hot spots and cold spots within the patient. PET, positron emission tomography. So PET uses a radionuclide tracer similar to the naturally occurring substances in the body, such as carbon, oxygen, nitrogen, and glucose. The imaging distribution of the tracer allows for demonstration of detailed metabolic activity of the area of interest. It is especially useful in cardiology, oncology, and neurology. So this is what it looks like for PET images. A lot of times we'll infuse them together with MRI or CT so that we can get better detail. All right, so we use a radiopharmaceutical also, and where gamma X-rays are created, and then we use two opposite gamma cameras to detect the radiation simultaneously, and then we can put it into 3D and color. All right, fusion imaging combines the anatomical images with metabolic function images. It increases the accuracy of diagnosis. All right, so direct fusion imaging with PET-CT and SPECT-CT. And as you can see here, we have the CT here. We reconstructed it into a coronal plane, and then you have your nuclear medicine, and we fuse the two together so we can see the hot spots within the liver, and we fuse the CT on top of it so that we can get a better detail. It's exactly where it's at. So you have your sagittal, and you can see here, it's just the CT, and then here is the PET scan, and then the two fuse together. All right, so combination of two imaging modalities, most common PET-CT. It's integrated imaging, so there's software that will lie both of them on top of each other. The image receptor is dependent on the modality used. So if we use SPECT, if we use PET, if we use MRI, if we use CT, so that's how the imaging works. Okay, let's get into the pathologies. Congenital or hereditary diseases of the bone. So first here we have vertebral anatomy or abnormalities, spinal bifida, osteoporosis, osteogenesis imperfecta, chondroplasia, and congenital hip dysplasia. So osteogenesis imperfecta. It's a serious autosomal dominant congenital disease affecting newborn skeletons, results in limb deformities and may lead to dwarfism, and abnormally fragile fragility of their bones. Infants affected with this disease are born with multiple fractures that heal, but only lead to new fractures. So it's a rare condition, and it tends to improve after childhood. So hearing disorders persist and due to connective tissue around the ossicles. So Osteogenesis Imperfecta is also named brittle bone disease. Is an inherent generalized disorder of connective tissue characterized by multiple fractures and unusual blue color of normally white sclera of the eyes. So the eyes will have a blue hinge to them. So you can see here this poor patient. You can see all the multiple fractures that have healed. And you can see here, this is Osteogenesis Imperfecta. This poor baby. All right. So chondroplasia, it's most common inherent disorder affecting the skeletal system, resulting in bone malformation and dwarfism. So the cartilage located in the epiphyseal of the long bones does not convert to bone in a normal manner. Patients with this type of osteochondroplasia present with a normal trunk size and shortened extremities. Additional clinical manifestations of the disorder include extreme lumbar spine lordosis, bow legs, and bulky foreheads. Occasionally, orthopedic surgery may be necessary to manage complications associated with the disease. These patients receive genetic and social counseling. So, chondroplasia is the most common form of dwarfism. It results from diminished proliferation of the cartilage in the growth plates, and it is autosomal dominant condition and is characterized by short limbs with normal axial skeletons. So, okay, here's a good picture. Looking here, a common sign of achondroplasia, you'll also see how large the head is and how small the mandible and the rest of the body is. Osteopetrosis. Now, osteopetrosis is kind of opposite of osteoporosis, so pay attention. Make sure you read the word correctly. So osteopetrosis is called marble bone. It's a term used to characterize a variety of disorders involving an increase in bone density and defective bone contour, often referred to as skeletal remodeling or modeling. It is important that the technologist be aware of osteopetrosis because it's going to change your techniques. So when you are scanning, if it's in MRI or CT, or if you're just shooting in a radiograph, you need to know that this is going to be really, really dense bone. It's not going to look normal. So, osteopetrosis is named marble bone. It is a rare hereditary dysplasia in which fractures of the reabsorbing mechanism of calcium cartilage interferes with the normal replacement of mature bone. It results in very brittle bones. So if you look here, you can see how dense the bones are. See how dark white they are, but yet they break super easy. So just like marble. And here's another picture. And this is a T1 spin density image showing hypodense end plates, parallel to the end plates consistent with sclerosis of osteopetrosis. So you can see how dense it is within the bone. That doesn't look like normal bone. All right, hand and foot malformations. No, this is a cool picture, huh? Can you imagine? Failure of the fingers or toes to separate. And it gives the appearance of web digits also, so people that have the web fingers and toes. Right, you can also have extra digits, which is really cool. Polydactyl refers to the presence of extra digits. We have clubfoot. It's a congenital malformation of the foot that prevents normal weight bearing. This foot is most commonly turned inward at the ankle. It's more common in males and occurs bilaterally. It's generally corrected by casting or splinting the foot in normal anatomical position. So here's some pictures of what it looks like on MR. So, ouch. Congenital dislocation of the hip. It's a malformation of the acetabulum, often results in congenital hip dislocations. Acetabulum does not completely form. The head of the femur is displaced superior and posteriorly. Ligaments and tendons responsible for the proper placement of the femoral head are also affected. It's more frequent in females, most commonly treated with embolization through casting and splinting of the affected hip. So you'll see kids with both hips in what we call a frog-like position, where they're casted with their legs going in an outward direction. So you can see here, this is not normal. And you can see this looks pretty normal, and this one does not. You can see it's displaced. Scoliosis, the abnormal lateral curvature of the spine. It's hereditary disorder, does not generally become visually apparent until adolescence, affects females more than males. It's radiographically important in diagnosis and treatment of the disorder. AP and lateral projections with proper shielding is important. Scoliosis, twisting or curvature of the spine. It's somewhat of an S-shaped, and the common types are idiopathic, functional, neuromuscular, and degenerative. So you can see here the scoliosis on this case. So sad. And as a radiologist, they go through and they take these measurements and look to see, and they'll measure the angles on how much it's off. Here's a cool MRI so that you can see exactly the curvature. That's a coronal plane. Spondylolysis is cleft in the pars interarticularis without displacement. It's usually bilateral. It's most common at the site of L5. So here you can see it doesn't look normal. Here, fine. This does not look normal. So you can see your superior articular process. You have your pedicle, your transverse process, and your pars interarticularis, and your inferior articularis. So you can see here this is thinning. And it is forward displacement of one vertebra on top of the other. This spondylolisthesis, sorry, is the displacement of one on top of the other, is the most common chronic back pain, and it can be caused by spondylolisthesis. So you can see the displacement. These should be lined up like these are. So you see how far off step it is. And you can see right there through the neck. All right, summary of the common spinal disorders. I'll let you go ahead and take a look at that on your own. This will help you with your quiz. And then vertebral abnormalities. So transitional vertebral body. So takes on the characteristic of both vertebra, and on each side of the major division of the spine. It can be in the C-spine or the L-spine. It's more common in the junction between the thoracic and lumbar, or the transition between the lumbar and the sacrum. So this is just an extra body, and boy, oh boy, an MRI does it throw us off. So if we look here, we have 5, 4, 3, 2, 1, and then we look here and it's like, okay, so this is 4, 3, 2, 1, and 12. And we look here, this looks like a body, doesn't it? So I would count that 5, 4, 3, 2, 1. But no, this is S1. This is or L6. We typically call it S1. But oh boy, does it throw you off. So really hard to see when you're scanning. I will actually do a sagittal all the way up, and I'll count to make sure that I've got everything covered, or I'll just make sure I cover more to ensure that I'm not clipping. This will throw you off every time. You can see here, it looks like an extra, looks weird down here, and you can't tell which one's S1 and L5. So S1, L5, 4, 3, 2, 1. So that is S1. That looks like L5 to me. So tough one. Spinal bifida, incomplete closure of the vertebral canal, and it's common in the lumbar sacral area, and it is failure of the bony fusion of the two lamina. And you can see it radiographically. Spinal bifida is a spinal canal defect, and it's caused from failure of the posterior elements. And spinal bifida occulta is a mild insignificant form in which there is a splitting of the bony neural canal at L5S1. Large defects have complications of hernias, so there's meningeal cell and myelomeningeal cells. So looking here, spinal bifida occulta here, and then you can see we have the meningeocele, and then the myelomeningeal cells is where you actually have part of the nerves going into the sac, which is a big problem. A lot of the patients are paralyzed from that point. So this is a meningeomyocele right here. You can see that it's got a huge mass in the back. And here also, we've got problem on your sagittal MRI. And here's a summary of your congenital hereditary bone diseases. I'll let you review that on your own. Lots of them. Inflammatory disease. First one we're going to cover is osteomyelitis. It's an infection of the bone and the bone marrow, often caused by Staphylococcus delivered via the bloodstream. It results from direct infection such as an open fracture. Acute stage is characterized by formation of an abscess leading to inflammation reaction within the bone, causing it to rise in internal bone pressure. The radiographs demonstrate soft tissue swelling in the area around the affected bone. Follow-up radiographs can be performed in 10 to 14 days after medical treatment to aid in the diagnosis. It's treated with antibiotics. Chronic osteomyelitis is characterized by extensive bone destruction and irregular sclerotic reaction throughout the bone. An accurate diagnosis is extremely important in helping and distinguish osteomyelitis from neoplastic bone disease. Nuke Med and MRI are best modalities for diagnosis of osteomyelitis. So we're looking here, you can see this bone is eroding away. It's really important to be able to diagnose that quickly. And this is chronic osteomyelitis of the knee. Yikes, so it's completely fused together. And you can see it here. This is chronic osteomyelitis. And here, oh, yikes. So you can see that whole bone is being eroded away. Tuberculosis. Okay, so we can get tuberculosis in the skeletal system. So, a chronic inflammatory disease that affects the ends of long bones of the spine. Disease, or radiographically, the ends of the bones display worm-eaten appearance. Disease slowly destroys the epiphysis, spreading to articular cartilage and in some cases of infecting the joint space. TB of the spine is also called Pott's disease, so really important there, so make sure you pay attention to that. It destroys the spine, causing softening and eventually collapsing of the vertebra, and results in perivertebral abscess formation and exerts abnormal pressure on the spinal cord. Yeesh. Okay, so TB, tuberculosis arthritis, is a chronic indolent infection that has a gradual onset and a slowly progressive course. It usually involves one joint, usually the spine, hips, and knees, and most patients that have pulmonary TB that have this. So here you go. This is a hip of a 47-year-old man with excessive destruction of the femoral head. It's gone. And neck caused by TB. How sad is that? And there's a huge abscess here also. So this is the abscess, and you can see that the whole head and neck is gone. Eaten away by TB. All right, and here you can see a big hunk. It looks like it's been bitten out of this knee. It's got a big bite taken out. Yikes. And of the spine. I've seen this multiple times. Not good. So you can see how it's compressing the cord there. Not good. All right, so tuberculosis of the brain. It can go up into the brain, and this is what it looks like. I've seen that. Not good. Pott's disease, so you can see it in the spine. Bursitis. All right. Inflammation of the small fluid-filled sacs located near the joint that reduce the friction caused by movement. So it can be caused by repeated physical activity. That's most common. Trauma, rheumatoid arthritis, gout, and infections. Rotator cuff tears. The rotator cuff of the shoulder can can be torn. Tears produce communication between the shoulder joint and the submucosal bursa. MRI is a modality of choice. So we're looking at rotator cuff tears all in here. You can see all the extra fluid. That's not normal. All right. Tears in the menisci of the knee. So we have tears are common in the knee and they cause knee pain. They can be acute from trauma or just degenerative, and MRI is your modality of choice. And you can see this little flap right there, and that is your meniscal tear in the knee. Arthritis. So, joint inflammation, it may be caused by a variety of etiological factors. Arthritis may be further classified as acute or chronic, and most forms are chronic and disabling. Acute arthritis is commonly called pyogenic arthritis and is caused by a variety of factors such as staph, strep, or gonococci, I don't know. Common clinical symptoms of acute arthritis are pain, red swelling of the affected joint. Sometimes you get fever with it. Early radiographic changes demonstrate an increase in joint space, bony destruction, and joint dislocation. And these are the common areas for arthritis. So here, arthritis, you can see bone spurs forming, narrowing of the joint space, normal. That's arthritis. Rheumatoid arthritis, all right. Usually occurs between ages 30 to 40. Symptoms include pain, swelling, stiffness of the affected joints, and as the disease progresses, cortical erosion and joint space narrowing due to overgrowth of the synovial tissue within the articular spaces. Eventually, the joints become fused, which requires surgical intervention. It may fluctuate in severity, and it can be an autoimmune disease. It's 3 times more common in females. It's a systemic disease of connective tissue, and the severity, the severe damage makes the joint unusable and leads to deformity. So you see those patients with all kinds of changes within their hands. There's also RA variants, which is ankylosing spondylitis, Reiter's, and psoriatic arthritis. So you can see that the left hand here has a lot of joint changes due to RA. And MRI of RA, you can see the edema within. Ankylosing spondylitis. All right. It is a progressive form of arthritis, mainly involving the spine. Affects males between 10 and 30. Early stages, radiographic changes demonstrate bilateral narrowing or fuzziness of the SI joints. Later radiographic changes show calcification of the bone of the spine and the vertebral ligaments. Leads to bone fusion and calcifications of the annulus fibrosus of the inner vertebral disc and the anterior lateral spinous ligaments. The spine becomes rigid. Rigid blocks of bone, giving the characteristics of bamboo spine. So that's when you hear ankylosing spondylitis, I want you to think bamboo spine. It affects the SI joints, so they become fuzzy and hazy. So in here, so right in here, you'll see fuzz and haze, and you can see the bamboo spine. See how it looks like a piece of bamboo? So bamboo spine where it's fusing. You can see it's fused together. And it can be of the neck also. So there's your bamboo. And the SI joints, you can see how they don't look normal. They look abnormal. They're fuzzy. They should be clear. Osteoarthritis. All right, most common type of arthritis is also known as degenerative joint disease. It affects males and females equally, results from non-inflammatory deterioration of the joint cartilage, and occurs with normal wear and tear of aging. It's also secondary to bone stress associated with trauma. So if you have any fractures, you can get osteoarthritis. Usually affects large weight-bearing joints of the body and interphalangeal joints of the fingers. Radiographically, this loss of articular cartilage appears as narrowing of the joint space. Clinically presents with pain and progressive stiffening of the joint. Treatment consists of surgical prosthetic replacements to relieve the pain and allow return of joint mobility. So as you can see here, you have osteoarthritis, you have swelling of the knuckles, and you have the Hemberden nodes of the fingers. And here is your osteoarthritis going and going and going. This is what it looks like on MR, so you can see the joint swelling and deterioration. And overview of your infectious disorders there. And your tears. So metabolic disease, bone diseases. We have osteoporosis, osteomalacia, rickets, gouts, and Paget's disease. Osteopetrosis is known as a metabolic bone disorder common in women post-menopause, and its lack of hormone estrogen creates a weakness in the bony matrix characterized by abnormal density in the bone. This condition becomes more severe. These bones are subject to compression fractures, and they literally just cave in. They just break. It is best demonstrated in the spine, where decreased bone density stands out clearly against the bony cortex. This condition requires a decrease in exposures. And treatment generally, osteoporosis is by far the most common form of metabolic bone disease and can be differentiated from osteomalacia by examining the serum enzyme levels. Treatment generally includes increased diet intake of calcium, vitamin D, and sex hormone supplements. So you can see we have a wedge fracture right there, compression fracture. And compression fractures here, 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 all over. Osteomalacia, condition caused by a lack of calcium in the tissues and failure of the bone tissue to calcify. Normally results from an inadequate intake of calcium, phosphorus, and vitamin D. The bones remain sponge-like, resemble osteoporosis in radiographic appearance. Lab analysis you need to do to differentiate between the two. Osteomalacia occurs before growth plates close, and if it is, it's known as rickets. So for kids, osteomalacia is called rickets. Adequate calcium, phosphorus, vitamin D intake can prevent or frequently cure this disorder. Yay! So looking here, you can see normal bone versus rickets or osteomalacia, and you can see the bowing from the softening of the bone. And other types, knock knees, bow-legged, and metabolic disorders here. Ouch. Rickets is a systemic disease of infancy and childhood that is equivalent to osteomalacia in adults. So calcification of growing skeletal elements is defective because of a deficiency in vitamin D in the diet or a lack of exposure to ultraviolet radiation, sunshine, which converts steroids, I think that's supposed to be steroids in the skin into vitamin D. Yeah. Okay. So looking at rickets, so before and after. You can see the bone, how it's not quite right versus after treatment. Looks much better, much healthier. Gout. Gout is a disorder of the metabolism of purine, a component of uric acid, neurolytic, so nucleic acids, geez Louise, is an increase in uric acid in the blood, which leads to deposits of uric acid crystals in the joints, cartilage, and the kidneys. Gout manifests as a very painful arthritis initially and attacks a single joint, primarily the first metatarsal phalangeal joint. And you can see here the gout. Ouch. Paget's disease. So Paget's is a metabolic disorder of unknown etiology, fairly common in the elderly population. It affects males twice as much as females. Most commonly involves the pelvis, spine, skull, and long bones. Has 2 stages. So one where the bone undergoes continuous destruction. Simultaneously, it replaces abnormal soft and poorly mineralized. So it's breaking it down and it's building it back up, but not with normal bone. So thicker than normal bone is softness often leads to weight-bearing, stress-induced deformities and fractures. So as the skull enlarges, additional complications occur because of enlargement of the cranial nerves. The complications include hearing and visual disturbances. So increased risk of developing osteogenic sarcoma. radionuclide bone scans readily detect Paget's disease. Radiographically, the affected bone is typically demonstrates cortical thickening with the coarse, thickened trabecular pattern. There is no known cure for this disease, and you can see it here. So the bone gets broken down and is repairing itself with abnormal bone. So you can see how thick the skull is, and you can see all these little spots. That's abnormal. All these spots are abnormal. And you can get Paget's disease of the breast, so you get red scaling and flakiness at the nipple, and it can be an underlying ductal carcinoma. It can lead to that. So, hyperparathyroidism, fairly common disease of the endocrine system. Hyperparathyroidism applies to any disorder that disrupts calcium phosphate ratios and results in an elevated level of parathyroid hormone. So the excessive PTH secretions overstimulate the osteoclasts that are responsible for bone removal, thus leading to bony destruction. This results in decreased bone density, so decreasing your exposure is necessary. You can see here, you get the salt and pepper appearance of the skull from hyperparathyroidism. And here is your metabolic disorder overview. And you have fibrous dysplasia is characterized by the proliferation of fibrous tissue within the medullary cavity. It causes loss of trabecular markings and widening of the bone. And you can see it here. Ischemic necrosis of the bone. Cause is due to a decrease in blood supply. It can be from thrombus or steroid therapy, Cushing's disease, any of the ones listed here. And ischemic necrosis, you can see the bone dying, and you can see it's eroded away down to nothing here. Neoplasms. So, benign tumors, bone tumors. So, there's a bunch of them. So, here we go. Osteochondromas. It's also termed exotosis. It's a benign projection of the bone with a cartilaginous cap, and it arises in childhood or in the teens. It's common near the knee. The characteristics of the long axis of the tumor runs parallel to the bone shaft and it points away from the nearest joint. So this is what it looks like. That's an osteochondroma. Endochondroma. So our low growing, which is interesting, benign cartilaginous tumors arising in the medullary canal. They are primarily in small bones of the hands and the feet. They are often found with fractures occurring with minimal force. Radiographically appear as radiolucent lesions containing small striped calcifications. They appear bubbly. So here you go. You can see it here, osteochondromas. Ouch. Giant cell tumor or osteoclastomas are typically arise at the end of the distal femur or proximal tibia of young adults after epithelial closures. 20 to 40 years old, does not affect the joint. So you can see giant cell tumor right here. Ouch. Osteomas. So most often arise in the outer table of the skull, the paranasal sinuses, especially the frontal and ethmoid, and the mandible. They cause pain, and they appear radiographically well circumscribed, extremely dense, round lesions that are rarely larger than 2 centimeters. Oh, right there, the little guy right there. That's in the frontal sinus. Osteoid osteoma. So osteomas is typically imaged as a small, round, or oval, loose in center, less than 1 centimeter in diameter, and is surrounded by a large, dense, sclerotic zone of cortical thickening. It's most common in teenagers and adults. Symptoms is local pain, which increases at night and is easily relieved by aspirin. So you can see in here, right there. Osteoma. Simple bone cyst is a true filled cyst with a wall of fibrous tissue, which most often occurs in the proximal humerus and femur at the metaphysis. Is asymptomatic and is often discovered either incidentally or after a pathological fracture. So here you go, simple bone cyst. So you can see how it's thinned. and they could break that pretty easy. Aneurysmal bone cyst is not a true neoplasm or cyst. It contains its contents of numerous blood-filled arteriovenous communication thought to be caused by trauma. So you can see right here, it looks like a bone cyst, but it's actually filled with blood vessels that are all knotted up. Bone island are solid, sharply and areas of bone that's compact and occurs most commonly in the pelvis and the femur. They appear in every bone except the skull. And there's one right there, the simple, easy little bone island. And here are your benign tumors and your review. So make sure you review those. That'll help you with your exam. And then we have malignant bone tumors. Osteogenic sarcoma generally occurs in the ends of long bones and especially around the knee. It is a malignant tumor of osteoblasts, which produced osteoid and specules of calcified bone. It's most common between 10 and 25. So smaller peaks of incidence is seen in older patients who have pre-existing bone disorders, especially Paget's. Oh, so this is a knee. So here's your knee joint, and you can see all of this is the osteogenic sarcoma. And on x-ray, you can see how it's got the sun spray, the rays coming off of it. It looks speculated. And right here, you can see it. Chondrosarcoma is a malignant tumor of the cartilaginous origin and may originate anew or within pre-existing cartilaginous lesions. Commonly occur in long bones, but often originate in ribs, scapular, or the vertebrae. It is about half as common as osteogenic sarcoma. It develops at a later age, peak incidence 35 to 60, and grows more slowly and metastasizes later. So this is what it looks like right here. See this big, huge thing. Irwin's sarcoma is a primary malignant tumor arising from the bone marrow of long bones. It occurs in children and young adults. It's rare over the age of 30. And all this. All the way up. Multiple myeloma is a widespread malignancy of the plasma cells. It's associated with bone destruction, bone marrow failure, hypercalcemia, renal failure, and recurrent infections. This disease affects primary persons between 40 and 70. And this is what it looks like at the skull. Oof. Bone mets, common malignant bone tumors. They are more common than primary. They spread from primary tumors by means of blood or lymphatic. Most common primary tumors are carcinoma of the breast, lung, prostate, kidney, and thyroid. Favorite sites of metastatic spread are bones containing red bone marrow, such as the spine, pelvis, ribs, skull, and upper ends of the humerus and femur. So you can see these white fluffy spots within, that is bone mets. So here they're all over, and here you can see all this, a bunch of them all in the pelvis, and it's eroded away there, completely eroded. You can see it's completely eaten away the whole humerus here. And here's your malignant bone review and bone fractures, the basics. What is a fracture? Fracture is the medical term for a broken bone. Fractures are common, and people usually have 2 in their lifetime. They occur when the physical force exerts on the bone is stronger than the bone itself. Broken bones are common in childhood. Children's fractures are generally less complicated than fractures in adults. They heal faster too. As you age, the bones become more brittle, and you're more likely to suffer fractures from falls that would normally not cause fractures when you're younger. There's displaced or non-displaced fractures, refer to the way the bone breaks. The bone snaps in 2 or more parts and moves so that the 2 ends are not lined up straight. Comminuted fractures are bone in many pieces, and non-displaced fractures is just a crack in the bone where it's not separated. So you can see them here. We have closed, open, or compound. Open means it's gone through the skin. Green stick means it's broken just part of it. And here are the different fractures. There's green stick, which is incomplete fracture. You have transverse fracture, which is at right angles to the axis. Oblique is when the break is curved or slope pattern. Comminuted is when a bone fragments into a bunch of pieces. Impacted is one whose ends are driven one into the other. It's seen in children a lot, and you'll get buccal fractures with those also. Other types of fractures is stress fracture, hairline, or pathological. So you can see the different ones here. Closed fractures, when the bone is broken but it didn't break the skin. And open is where the skin is broken, and it's important that you know the difference. All right, so soft tissue involvement. So you can see a closed fracture here. Clearly the bone is not straight, the arm is not straight, so the bone is broken, and you have an open fracture here. That's a pretty good one. All right, so the severity of a fracture depends upon its location and the damage done to the bone and the tissue near it. Serious fractures can have dangerous complications if not treated properly. Possible complications include damage to blood vessels and nerves, and you can get infection. Recuperation time depends on the age and health of the patient and the type of fracture. Minor fractures in children may heal within weeks, and serious in adults it can take months. So fractures of the cervical spine. If you fracture C1, you can have a Jefferson fracture. Fracture C2 is hangman. And you can have teardrop fracture, which is of the antero-inferior aspect of the cervical vertebral. So you get a chip broken off there. And you can have clay shovelers right here. And teardrop again with compression. We get this from diving. So people that dive into a swimming pool that's shallow, so they'll get a fracture in their quadriplegics, or they hit the sandbar in the ocean. I had that a lot down in Newport Beach. So teardrop here, you can see that. And burst fracture, in which the vertebrae breaks from high energy axial load. So something hits someone on the top of the head, you can see it just completely crush that vertebral body. So compression fracture coming down right here. Oh, right there. And you can see that the spinal cord is affected in this. So the different fractures, so you can understand how they happen. Fractures of the hand, so scaphoid fracture, these get avascular necrosis all the time as they don't have a lot of blood supply, so they take a long time to heal and they get avascular necrosis. So you can see here on MRI, we have a fracture of the scaphoid. And we have boxer fracture, which is fracture of the neck of usually the 4th or the 5th. And we have the femoral shaft fracture. Ouch! Look at that one. March fractures, so we have Jones fractures right there, so the base of the 5th. We always want to catch that on an x-ray or an MRI. You want to make sure you get that on there so that you can see if there is a fracture. And we have March fractures. You can see the remodeling of the bone, so this is the bone healing, so you know that there's a fracture there. So stress fractures, you can see all the brightness of the fluid, so you know that there's a fracture or some kind of trauma there. Calcaneal fracture, oof. Down in Mexico, they jump over the wall and they break their calcaneus all the time. So we did a lot of those down in San Diego. So signs and symptoms here. The bone itself contains no neuroreceptors, so bone fracture is very painful for several reasons. One, there's a break in the continuity of the periosteum with or without similar discontinuation of the endosteum, and the edema of the nearby soft tissue caused by bleeding and torn periosteal blood vessels invoke pressure and pain. Muscle spasms trying to hold the bone fragment in place and damage to adjacent structures causes all the pain. All right, the effects of nicotine. So those of you who smoke, sit up and pay attention. Smokers generally have a lower bone density than non-smokers, so have a much higher risk of fracture. There's also evidence that smoking delays bone healing. Some research indicates, for example, that delays tibial Shaft fractures healing from a median time of 136 to a median of 269 days. This means that a fracture healing time was approximately double in people who smoke. Compartment syndrome. Now, this is a serious side effect of, or complication, I should say, of fractures. If not treated, compartment syndrome can result in amputation of the limb. So what happens is there's connective tissue that keeps all the muscles where they're supposed to be, and it starts to bleed or swell within that area, and it'll cut off the blood supply. So other complications may include non-union, where the fracture bone fails to heal, malunion, where the fracture bone heals in a deformed manner. So compartment syndrome is pretty serious. Okay, we did it. So just under an hour. A lot of information. Make sure you read your book so you can do well on your quiz.